Hello everyone, my name is Lucas Kopp and I am a first-year medical student at Michigan State University College of Human Medicine. Today I will speak to you about my project, Optimizing Cost Effectiveness in Trigger Finger Release, Hospital Outpatient versus Ambulatory Surgical Center. Healthcare costs are steadily rising and it has become paramount to optimize the delivery of our care to patients undergoing procedures. Ours is a comparative cost study investigating the value of performing trigger finger release surgery in different surgical settings used by providers. The goal of our study was to examine the impact of different surgical settings on both the outcome and cost of trigger finger procedures. We hypothesized that ambulatory surgical centers would provide greater value over hospital outpatient procedure departments, both by lowering overall costs and by providing similar or superior outcomes. We enrolled 11 patients undergoing trigger finger release surgery at an ambulatory surgical center and 22 undergoing trigger finger release surgery at a hospital outpatient procedure department. To measure costs, our team employed time-driven activity-based costing, where a team member followed the patient through each step of the procedure to collect the direct labor costs for all personnel that interacted with the patient. These costs were combined with the cost of supplies to calculate the direct variable costs. We also factored in the direct fixed costs, or overhead and building fees, and indirect costs, categorized by administration and marketing costs. Our outcomes of interest were measured with patient-reported outcomes collected by surveying patients preoperatively and 3 months post-operation. Our PROs are comprised of PROMIS upper extremity and PROMIS pain interference. PROMIS upper extremity was used to assess hand functionality, and a higher score indicated improvement, while PROMIS pain interference indicated pain that compromised daily activities and the patient's overall well-being, with a higher score showing regression. The difference in baseline PROMIS scores 3 months post-operatively were used in the calculation of PROMIS adjusted life years, or PALYs. PALYs were calculated by measuring the difference in PROMIS scores by the length of effectiveness for trigger finger release, which remained constant at both sites. Our measurement of value was based on our calculations of average cost effectiveness ratio, ACER, for both ambulatory surgical centers and hospital outpatient procedure departments. These measures were calculated by dividing the aforementioned costs by incremental effectiveness, shown in patient-reported outcomes, with a lower number indicating higher value. These ACERs were compared to calculate the incremental cost-effectiveness ratios, or ICERs. Please refer to Figure 1 for a visualization of our exact calculations for these values. Our results indicate that total costs for trigger finger release surgery were significantly higher in ambulatory surgical centers than hospital outpatient procedure departments by an average of approximately $1,000 per procedure. This can be best viewed in Figure 2. Additionally, ASC PALYs for upper extremity and pain interference were insignificantly higher than those from hospital outpatient procedure departments. Turning our attention to Figure 3 and Figure 4, we found mixed results in that ACERs for PROMIS pain interference were lower in the HOPD, while ACERs for PROMIS upper extremity were lower in the ASC. However, ICERs indicated a higher total cost-effective management for pain at hospital outpatient procedure departments. Our findings present that ambulatory surgical centers and hospital outpatient procedure departments are more cost-effective for different aspects of patient-reported outcomes, while hospital outpatient procedure departments provide the most overall cost-effectiveness for trigger finger release surgery. It is important for physicians and administrators to take these differences into account. Our study serves as a model for considering direct and indirect costs in the context of improving patient outcomes, which is undoubtedly important as more emphasis continues to be placed on value-based care. Thank you to my co-authors, Richard Tuttle, Noor Aldin, Kamaluddin, Meet Patel, and our PI, Dr. Charles S. Day from Henry Ford Health in Detroit, Michigan. Thank you very much and have a great day. I appreciate your time.